The enrollment opportunity that exists today is the open enrollment. And so we'll just briefly go through a couple of slides to make sure that individuals understand the opportunities that do exist and clarify what can be done during OEP. OEP starts January 1 and goes through March 31st. Typically, it is only for individuals who are enrolled as of January 1 in a Medicare Advantage plan. And that means two things. It means that either they made a change during AEP and became effectively enrolled with that new plan on January 1, or they did not make any changes and stayed with the existing plan and obviously became effective January 1 of this year. Those two categories of individuals have the ability to switch from one Medicare Advantage prescription drug plan to another. However, new Medicare beneficiaries enrolled in an MA plan during their initial coverage election period, these enrollees do get an MA OEP, but that starts the first month of entitlement to their Medicare's Part A and B and ends the last day of the third month of entitlement. So if that individual became Medicare eligible starting February 1st, they have a MA OEP from February 1st through the end of April. Okay, so it is an actual MA OEP for them. It does extend that time offering that allows them to join a Medicare Advantage plan. But working parallel to this is another election period, and that's called a general enrollment period. And a lot of people miss this opportunity. Because of the Inflation Reduction Act, there was a removal of gap in coverage. And so historically, these individuals who were applying for their Medicare Part B in this same time period, January 1 through March 31st, their Part B coverage did not become effective until July 1 of the same year. But that Deficit or Inflation Reduction Act now allows them to become effective the first of the following month. And so for those individuals who opted in to their Part B in January, they became effective February 1. And those so forth who opted in February become effective March, and those who opted in March become effective in April. The benefit to you as a selling community is that creates a 60-day SEP from the first of that effective month. So basically, they become effective February, they have March and April to the end of April to capitalize on that SEP. And for those who at the end choose to elect for Part B in March, you also have April and May, the end of May. So it gives you 2 additional months of enrollment opportunities, right? Unlike that OEP, which is structured only January through March, you do have an additional extended period for these individuals who qualify. Keep in mind that some of these individuals may actually be assessed a late fee depending on what their individual circumstance is, because have they gone beyond a full 12-month period without enrolling in Part B, they may be subject to a late enrollment penalty. And for Part B, late enrollment penalty is 10% of their Part B premium. And we know that the minimum Part B this year is $185. So you're talking about an extra $18.50. Right, so I'm speaking a little ahead of myself, but this is just a highlight to that point, that you have a 2 additional window period of opportunity to enroll these individuals. So Part D redesign is also a part of the CMS rule changes for 2025. How does that impact right member, right plan, you, and selling opportunities? So with regard to Healthfirst, it has caused us to take some of that redesign and pass some of that cost sharing on to the member. And it's passed on to them in 3 of our plans, 65 plus, Signature HMO, and Signature PPO. All have a $590 deductible. However, that deductible only applies to Tier 4 and Tier 5 level drugs. Tier 1 preferred generic drugs is still a $0 copay across all plans. Tier 2, the generic drugs, there is a slight increase of $5 for 30-day coverage and a $10 increase for 60-day coverage. However, these 2 tier levels, 2 and 3, will still have the 90-day incentive remaining. So in other words, that member who is not having quantity limit drugs prescribed will be able to take advantage of getting a 90-day fill at a $30-day cost rather, right? So for a 30-day cost, they'll still be able to pay that amount for a 90-day fill, right? And that's for 65 plus, Signature HMO, and Signature PPO members. That's a tremendous cost savings for that individual. If they're traveling, inclement weather, incapacitated, they'll be able to have those savings still, even though there's a slight increase. Tier 3, preferred brands and drugs, they also will have that same 90-day incentive, $35 as you see for 90 days, $47 for Signature HMO and PPO. Our life improvement and our increased benefit plan will also still continue to have a $0 copay at Tier 1, 2, and 3 levels. However, our life improvement plan members will now be responsible for paying their LIS cost share levels at the Tier 4 and Tier 5 prescription drug fill. Individuals in 65 plus, Signature HMO and Signature PPO, we've increased our Tier 4 cost share, where it was once $100 in 2024, it is now a 50% co-insurance. So that is a cost share reallocation that the member becomes responsible for. How does the member get help from that? It depends on where they are in the process, okay? And so we'll talk a little bit more to this before we actually go to how those members receive help, because depending on what that individual's LIS level is, will determine what their cost share is. And so LIS level 1, they would pay a $4.90 for generics and $12.15. And then obviously those at cost level 2 would pay generics $160 and $4.80. That's a difference between obviously last year and this year, because of the fact that last year they were getting all levels of prescriptions for free. And then the maximum monthly cap on cost sharing payments is based on the Medicare monthly payment program that allows individuals to pick up their prescription at no cost at the pharmacy and be billed over the course of the remaining months of the year. But that full amount of the cost of that medication will still go towards that $2,000 maximum cap. And so if you look at an example where an individual was having a medication that cost $800, their cost share now is $400 because it's a 50% co-insurance. And that individual would have each month's billed amount to them based on the prorated amount of months left in the year. And obviously each month causes that monthly payment to increase plus be added to the previous month. But once they reach their cap, in this case, they'll be capped at $2,000 in May, they will not have an increase in the amount of money they pay monthly for the rest of the year. So it allows that individual to spread out that cost share and not have to take the heavy burden of paying $400 a month for the year. So it's a great program. You have to register in order to participate in the program. And they stop any additional costs for months 6 through 12. All right, so it's a great program for them. So what are the other changes? The other changes are the removal of the quarterly LIS. And so this is the one that we really want to focus on and have some explanation. We know that CMS is replacing that quarterly SEP with a monthly SEP that allows individuals to essentially disenroll, go back to original Medicare. And we truly want to be sure that we educate them so that they understand the loss of those added value benefits once they leave. But what about those individuals that want to actually enroll? CMS has created a new integrated care SEP to allow dual eligible individuals to elect an integrated D-SNP once per month. So let's talk about what that means, where it states that it must be an aligned enrollment. And so what does an aligned enrollment actually entail? Aligned enrollment means that an individual has to have an underlying Medicaid program being covered by the same carrier plan in order for them to enroll into that plan's dual special needs plan from April 1 through October 14th. Right now, OEP is an open enrollment. They can go into any D-SNP plan without having a corresponding Medicaid program until March 31st. Once we hit April 1, that individual will no longer be able to go to an unaligned plan. And so let's break that down. So there's two categories in which an individual can actually enroll into a carrier that has a corresponding Medicaid plan providing services to that beneficiary. The first is FIDE, which is called a fully integrated dual eligible. FIDEs are required to have exclusively aligned enrollment, right? This means that all enrolled members receive both their Medicare and managed Medicaid benefits through the plan. The FIDE is required to provide nearly all Medicaid services, including long-term services and support, Medicaid behavioral health services, home health, and DME. That is typically called a MAP plan, right? And so for those who may not be familiar, a MAP is the coordinated benefits of both a long-term care and a Medicare Advantage plan being coordinated under one umbrella. However, HIDE, which is considered a highly integrated dual eligible, simply means that there's a requirement to cover long-term services and supports or behavioral health services, but may have more Medicaid services carved out as compared to a FIDE. And so that means that an individual can have, as we saw in this example, say Healthfirst Senior Health Partners Plan. That is a standalone, separate, managed long-term care program. It is not coordinated with LIP, but because it is under the umbrella of Healthfirst, there's communication between case managers to coordinate those benefits, but not all of the benefits that are being received have to come from one specific source, like a FIDE. So it's not a MAP plan. And so the way to benefit from a HIDE is, for example, if there's a member who has Healthfirst, SHIP, which is called our Senior Health Partners Plan, but they do not have a dual SNP plan with Healthfirst. Say they're with another carrier, and for the sake of this audience, they could be with Humana, or they could be with Cigna, it could be with Aetna. You could then enroll that individual into Healthfirst D-SNP plan, and it would be considered a HIDE. Once we receive that member, if we wanted to reach out to them and enlighten them to the extensive benefits that's available from a MAP plan, and get that individual to decide to want to enroll, we could do that. But you, as an initial broker that enrolls them into the LIP plan, will remain the agent of record. We are trying to work on a process that will allow the broker community to submit referrals for individuals who say are not enrolled in our senior health plan, so that you can submit that referral along with a future enrollment for a DSNP, where you're credited for both the referral and the enrollment, and get credit for the LIP enrollment and still be registered as the agent of record. Because as of right now, the broker channel is not authorized to enroll anyone into our complete care program. You're not trained for it. They don't have it as part of the annual certification process, and we'll continue to work on that. So let me pause, and I see there's some questions that are popping up in the channel. Let's see if we can review some of those questions.
Yeah, I think I got them. So one of the questions was, is Healthfirst only in New York? And I tried to answer you, and I think I hit delete by mistake, so I'm sorry about that one. But yes, Healthfirst is exclusive to New York. The topic that we're covering, you know, the FIDE and the HIDE, that's national. So that bit of information is relevant to everybody, whether you sell New York or not. But Healthfirst itself is a New York product. The next question here is states like Illinois that don't have official Medicaid working with Medicare would not fit this product. And I did reply to that. That is correct. The new changes, you know, basically mean a plan has to be fully integrated. So when this wraps up, I have a list from CMS, national list of all the states that have integrated dual plans and by carrier. And I'll email that out to everybody on this call so that you'll know where you have HIDE, FIDEs and such. And I think
yes,
that's, otherwise we're good, Eugene. Yeah, I think I got them all.
Okay, great. Yeah, I didn't see the New York one. So yeah, we're only in New York. It's
Yeah.
we keep asking, when are we going to go somewhere else? But you know, a few years back we were in Jersey, but that didn't quite work out for them. I wasn't here at the time, so no, just New York. And then only the lower, we call it the lower 10 counties plus Sullivan, right? So anyone that's familiar with New York, there's 62 counties. We're in the lower 11, basically. For your reference purposes. And so just as an example, if a beneficiary may utilize the new integrated care SEP to enroll, as we said in that previous example, just a little wordy to go with that chart, and they're already enrolled in our senior health partners or in the process of enrolling, and that's what we talked about, trying to create that referral process, that individual may become effective for SHIP, because the managed long-term care process can take anywhere from 30 to 45 days or 60 days, depending on what point in time in the month that individual reaches out with that referral. Referrals come from LICSAs, CHAs, right, long-term care agencies, short-term care agencies, home care agencies, senior daycares. They may be the sources of referrals, and that individual would have to have an initial medical assessment done by Maximus, which is New York State's enrollment broker, and now Medicare managed long-term care primary source of assessments. Their nurses go out, they assess that individual, and again, it depends on when their schedules allow for them, because they're getting those requests from all plans that have a managed long-term care program. I've heard that they're a little backed up, so it could be 2 weeks, 3 weeks, it could take a whole month. But once that assessment is made, there's a scoring grid that Maximus will send out back to that plan. And then based on that plan scoring grid, which by the way is good for 12 months, that plan will then send out their nurses to do what they call as a plan of care. They'll take that criteria from Maximus, speak and meet with that individual, and then make the determination how many hours, so on and so forth. And then that member has to agree to and sign off on that plan of care. And there's many instances where they won't sign that plan of care because they don't agree with it. And so if they're transferring from one managed long-term care to other, they have to be in agreement and approval. And so there's some obstacles and speed bumps along that process. But if all things go well, both assessments are made, all enrollments are submitted by the 20th of each month with effective date of the 1st of the following month. And so that's where that coordination of submission of applications for the life improvement plan with the SHIP, if it's a referral, that's a process that we're continuing to work out. However, a beneficiary may not utilize this new SEP to enroll into Healthfirst LIP if they have fee-for-service Medicaid or another carrier's MLTC, because their enrollment would not be aligned, right? So if they have fee-for-service Medicaid, no Medicaid managed care coverage, and they just want our dual eligible program, they will not be able to enroll in April and moving forward because the LIS SEP no longer exists. So instead, those beneficiaries may enroll in LIP during AEP, or if there's another qualified election period that would apply to them. Change in their Medicaid status, change of address, those type of SEPs, because additionally, beginning April 1 as well, CMS has sent out a dictation or memo that will no longer allow plans to accept directly from the beneficiary using the disaster relief or disaster declared SEP, commonly called FEMA. This change is a direct result of concerns that this SEP has been overused or misused. And so those individuals would not be able to use the FEMA SEP and come April. They'd have to have a different category of special election needs. And most often it's either they newly got Part B, or they the change of address or change in Medicaid status. Those would be the categories that would be available for enrollment now. There's a question there that I see, so let me speak to this more. Do you want me to take a moment?
Yeah, so I was just going to say, you know, like Joe, I know you were asking about how do I get in front of people in New York. I just want to point out Pedro does a really good job with events. So take his information, he put it in the chat box there for you. But Healthfirst, they're really good at having a lot of, you know, in-community events. And I think that would be an awesome way for you to get out in front of people and do some grassroots marketing. So take his info down. And then this other part, Eugene, yeah, we need you to answer more. With the changes in administration making more holistic options, do you think that you'll see plans covering holistic supplements in the future? And I'm going to let you speak to that one in better detail, better than I could probably.
Yeah, and that's really up in the air right now, because one of the things that I will say is that our organization has been really diligent with sending out communications, letting us know that they are being very diligent with regard to observing and listening to and interpreting any executive orders and what impact they may or may not have on the healthcare industry as a whole. But with regard to holistic supplements, that's an area that might be covered with regard to the over-the-counter items. And I can't speak to that wholeheartedly because I haven't went through the entire catalog of items to know if that's available or not. I don't know, Nilsa or Pedro, if you've went through that and encountered someone in the field asking for holistic supplements, but as of right now, I don't know if that's an area that is covered. And I know that, yeah, go ahead. You said something.
So from what I've experienced, right, from other brokers and even interactions with members themselves, so it really, it's not defined, right? It's not specified like which particular holistic items are included under the OTC coverage benefit, but it really comes down to the vendor, right? So the retail that offers it. So for example, major retails for us, it's pretty much all the major like CVS, Rite Aid, Duane Reade, all those pharmacies, right? A huge vendor for us as well is Walmart. You know, our OTC is accepted there. And then you have, you know, local supermarkets or the big name brand supermarkets like the Stop and Shops and the Western Reefs and, you know, all these other ones that are, you know, like part of the local community. But it comes down to the vendor. If you're looking for, you know, items like vitamins, specific oils, I want to say that I've seen that being covered, but I am not 100% sure. So if there's any specifics, you can feel free to reach out to me. I will likely, you know, go to the source, right? So I'll review within, you know, our Healthfirst partners that actually do manage the OTC benefit, and we can inquire with them and find out, you know, specifically. But in general, those are things that should be covered through the over-the-counter card.
Yeah, and that's a good input because we have CVS is our pharmacy vendor, and from communications that we get, they are in contract with us, so they kind of really have more design over the items that are covered or not covered. We can speak to it because I know there's always coverage area items that get confused whether or not they can be gotten directly from the pharmacy, or does the doctor have to write a prescription for certain items that they can take to the pharmacy? So CVS is the kind of overseer of that, and then we can communicate to our provider relations team to negotiate other areas if we feel that that's a need. But all of this with regard to the administration changes, I don't see whatever changes that they may implement affect us in this current benefit year, right? Because our contracts are already in for benefits, they're approved. And so typically when you send a contract in for that benefit year, you can't reduce benefits, right? You can only add or improve them. And so that's something that we really couldn't speak on right now because we haven't gotten any guidance for how any of those current executive orders have had an impact on us or not. So I hope that was helpful to the person who asked that question, and obviously for the rest of you who are listening. Any additional questions? Please ask. That's why we're here, right? So come on and let us know. Cool. I'm licensed in New York. How can I find clients that need me? Maybe you want to answer that out loud, Pedro. That's a great question. And obviously, this is why we're here providing support for those of you who are currently active in New York or those who want to become active in New York. Pedro, why don't you read that out loud so others can hear?
What is the question is in the chat?
Yeah, so it says,
okay.
Cool, I'm
licensed in New York. How can I find clients that need me? Well, my name is Pedro. I'm your account manager, and one of the things that I do for you guys is to help you development, with development on the field, marketing events, and all that. So every month I can create a list of events that I share with the brokers. But also, if you have any initiative or any idea that you wanna take action in your community or somewhere, you know, like I also can be the person to help you with that. We can put it together. If we need any kind of a sponsorship, I can help you submit all that and make it happen.
And then not so much for self-promotion. It's interesting. We have a couple of minutes, right, Serena?
Sorry, I'm on mute. Yes, you do. Yep.
Okay, great. So I embedded in this particular screen, and let's see if it actually comes alive for us. Sometimes it does, sometimes it doesn't. And I'm not going to go through the entire, but these are some of the tools that we have. And let me see if I have with audio. Yeah, so it says computer with audio. Okay, let's see if that happens. So I'm stopping it there because I just want you to see that we have many, many tools in addition to Pedro and Nilsa to help you in the field. We do have videos on the broker channel. We also have a lock-in video that really goes into identifying locations and opportunities. And then that's where the partnership and the collaboration with Pedro comes in, because he can work with you as well. So if you're really trying to get into New York, we have inroads and guidance to help you figure out how to navigate through a new territory.
Yeah, and just to add to that, you know, the onboarding process is very straightforward. So if you are interested, don't hesitate to reach out to us. It's just a quick link. You updating your information onto our system. We'll review, request a background check, and load you up. The great thing about Healthfirst is that, you know, it is the local brand. So it's small but mighty. There are over 285,000 Medicare lives already in Healthfirst. We've been in this industry for over 30 years, and this is a strong and local brand. The benefits are part of the best in New York. So if you're interested in just reviewing it, onboarding with us, working with us, please just, like I said before, just connect with us and we'll be able to help you guys out.
Yeah, and
my information is in the beginning of the chat in case that you need to reach out to Neil, or me. Please feel free to get in touch if you have any questions.
Absolutely, and one thing that I will add is retention. For those of you who are concerned about the D-SNP population, right? As there's very little windows of opportunities becoming available for the D-SNP population to move as much as they were historically perceived to move in the past. But when I do a broker orientation, we did one this morning, we're able to show and demonstrate that there are brokers who've been with us since 2021 that still have members on the book from 2021. So we have a tremendously high retention rate with our members. Right now we have the highest, or one of the highest in the country. And even though we're a hyper-local plan in New York only, with over 2 million members at Healthfirst, we're the 5th largest Medicare Advantage plan in the country, right? We've had the largest, we're in the top 10 for enrollment growth. For 2024, we're looking to see where we were for 2025 because we did even better. So we're growing at paces that are equivalent to national carrier levels here in just a hyper-local space. And the good thing for all of you who are considering entering into the New York market is that we continue to position ourselves as one of the top plans of choice, and we have a great track record for retention on your members, and that gives you the ability to build your book of business. And so I'm not sure if we have time. So Serena, based on our last conversation last month, I think the Part D redesign and Heidi was what we wanted to focus on this time around.
Yeah, Heidi was. Yeah. Yep.
Yeah.
Yep.
All right. So we thank you. Thank you. Sorry for the technical mix-ups, but we're here as always to come through and provide hopefully some helpful information and tidbits for you and your crew. And thank you for your time. Nilsa, do you want to have anything in closing?
No, that's about it. But thank you very much. I appreciate everyone for joining us today and hope you have a great rest of your week.
All right. Thanks, everybody. And I'll send out an email after we close here. Thank you.
Thank you very much.
Thank you.
Bye-bye.
Thanks. Bye, guys.